I'm delighted to participate in this conjoined session of API and CSI Karnataka chapter. So, Dr. Shankar, Dr. Sangram brother, Dr. Vivek Jolly, and all other organizing members. So, for the next 15 to 20 minutes, I'll be talking on STEMI. STEMI is a very vast topic, and therefore I will be showing you only some interesting cases rather than the conventional lecture on STEMI. For successful treatment of STEMI, your cath lab should be open round the clock 24 into 7. Now, this is just to show you how acute myocardial infarction develops. Acute myocardial infarction develops because of disruption of a vulnerable plaque. Moment the plaque disrupts, thrombogenic material is liberated into the blood, and this results in formation of a clot. And the territory of the infarct related artery, the myocardium which is supplied by it, undergoes necrosis. So the important issue in acute myocardial infarction for the physician is they must be able to localize the culprit artery, because there are certain subset of patient where, if possible and feasible, the patient must be referred to primary angioplasty. The results of primary angioplasty are much better than the lytic therapy or even the pharmacoinvasive approach. So let's see now, this is an electrocardiogram. I think all of us would very clearly say that this is acute anterior myocardial infarction, but the story should not finish. You must try to localize whether this is a proximal LAD or a distal AD, and this is very simple, as you can see in this slide. If the ST segment depression in the inferior leads, this becomes a proximal LAD. And if you have an electrocardiogram of proximal LAD occlusion, if possible and feasible, the patient must be referred from primary angioplasty. And these are why the ST segment gets depressed in the inferior leads, because of the vector, but I not. So single message for anterior infarction is always look on the inferior leads. If there is ST segment depression, this becomes a dangerous subset to be submitted for PCI if possible and feasible.
Dr.
Now
Manoria,
here,
your slides are not moving. Kindly share.
slides are not moving.
Yeah,
You are able to see the video?
yeah.
Oh. So now here you can see this patient has a proximal LAD occlusion and
Slides are not moving. Kindly.
not moving.
Yeah, not.
I'll share it again. Stop sharing. Now they are moving.
Yeah. Now then.
So we have said how to localize the lesion in the culprit LAD, ST segment depression in the inferior leads, and the angiogram, as you can see, shows occlusion of the proximal LAD, and angioplasty should be done, and then the patient improves. The more interesting problem is that this is again a patient of anterior myocardial infarction. I think all physicians will diagnose it very easily. But the problem here is that there is ST segment elevation in the inferior. This is lead 2, lead 3, and lead AF. And whenever a resident sees this, he always rings up the consultant. This is a patient of anterior and inferior infarction. This is a very high risk case, and you should come immediately. The reality is just paradox of it. This is a distal LAD lesion, so that if you get ST segment elevation in the inferior leads in a patient of anterior myocardial infarction, this is a rather less dangerous subset of acute myocardial infarction, and one has time to tackle with it. So when we do angiogram of this patient, again you would see that the distal LED was occluded and the artery has been opened up. Now, this is again a very important subset which all physicians must recognize right at the onset. Here again, I think all of us would say that this is acute inferior myocardial infarction. You have gross elevation of ST segment elevation in L2, L3, and AVF, and there's no debate on this. But what is very important is, again, in an RCA lesion, you have to recognize whether this is a proximal RCA lesion or a distal RCA lesion. If it is a proximal RCA lesion, this becomes a dangerous subset of myocardial infarction because the right ventricle is also gets infarcted. Usually the resident do not take the right-sided leads which is there for diagnosis of RV infarct. But even if you don't take right-sided leads, you can get a very clear hint from the 12-lead ECG. If the ST segment is markedly elevated in L3, which is a right-sided lead, this is very likely to be a right ventricular infarct, which means a proximal RCA. And the right-sided leads taken, you can see all these elevations in the right-sided leads. And this lasts for a short time, so that if you are delayed, this may not be there. But the simplest indicator for a suspicion of RV infarct is if the ST is markedly elevated. You don't see such ST elevation in day-to-day practice. There is associated, and this is a clear example that the patient is suffering from a proximal RCA lesion. And again, if possible and feasible, this patient must be submitted for an angioplasty. The results of angioplasty are good compared to conventional treatment, because once right ventricle gets infarcted, it's very difficult to treat these patients. And you will see again the angiogram very clearly shows that the RCA is occluded. And why we are so much concerned about proximal RCA, 30% of them also have a right ventricular infarct. Cardiogenic shock is more common, AV block is more common, and scar related VT from the right ventricle is also not uncommon. So now the angioplasty has been done. You can see this is the blocked artery, the artery is open, and look at the ECG. The ECG changes have reverted. So again, this is a dangerous subset which you should always recognize in time. Proximal circumflex is also a dangerous subset. Somehow that illustration case is not there in this PPT, so I'll skip over. The other thing which you must always try to recognize is this ECG, which you should never miss. Now, this is an electrocardiogram of a 55 years old male residing very near to our hospital. He develops severe chest pain. He immediately comes to the hospital, and this is the electrocardiogram sent on a WhatsApp by the resident. Now, if you look very carefully, again the story is anterior infarction is very clear. You have ST segment elevation in V1, V2, V3, and so on. So no doubt that this is a LED lesion. Now, the next step would be to see inferior leads. In inferior lead, you see marked ST segment depression, clearly indicating that this could be a proximal LED lesion. But the story does not finish it. Now, if you look at the AVR, the ST segment is elevated. So if an ST segment is elevated in AVR, this becomes either a left main occlusion, a triple vessel disease, or an RCA occlusion, proximal. RCA occlusion does not arise because the ST segment is depressed. So the differential is between a proximal uh, triple vessel disease or a very proximal LED occlusion or a left main occlusion. Now, if the AVR ST elevation is more in AVR compared to V1, this becomes a left main stem disease. But if it's the reverse, this is not left main disease. This is either a very proximal LED or a triple vessel disease. And if you look at ST segment elevation in 1 and AVL, there is ST elevation clearly indicating this patient has an infarct of the left anterior descending, this patient has an infarct of the circumflex territory. So the moment we saw this CT, we rushed to the hospital. The diagnosis was this is a right coronary artery, normal, and you can see the left main is totally occluded. The artery is opened, and you can see the patient survived and is still surviving. Otherwise, most of these patients would be dead. So you should always suspect a left main lesion also, and I have already told you how you can suspect. And this is electrocardiogram after the procedure, and this was finished almost within an hour. By 8 p.m. 6:50 the ECG was sent, and 8 o'clock the procedure over. So you can see this again is a very dangerous subset. You must submit, you must rather do primary angioplasty at the earliest, otherwise the patient will not survive. So that was about the culprit artery. Look, the second issue which we commonly face is lethal ventricular arrhythmias, which are also life-threatening. So let's look at this patient. He is a 65 years, 61 years old gentleman, presents to us in the OPD with chest pain, and while his electrocardiogram was recorded, he develops a cardiac arrest, you can see, but in the electrocardiogram, you can very easily see that there is a ST segment elevation in 1, there's ST segment elevation in ST segment depression in 2, 3, and then the patient has developed VT and ventricular fibrillation. So obviously the first step was to give a DC shock. It has reverted, and again you can see ST segment elevation in the precordial leads and ST segment depression in the inferior leads, clearly indicating this is again a dangerous subset of proximal LAD. While the patient was taken for primary angioplasty, he developed multiple episodes of ventricular fibrillation, and he was given DC shock. And so this is a classical case of a VT storm. Angioplasty was done, and somehow the VT storm subsided. So when faced with such a situation, the first step is that you have to convert this patient by a DC shock, as was done in this patient. The second step is you must open the artery. Ischemia is a very important determinant of this polymorphic VT, so either by lytic, PCI, whatever is feasible, antiplatelet and anticoagulant, whatever is. In terms of drug treatment, you can use amiodarone, lignocaine, or beta blocker, and there is always increased sympathetic activity which contributes to this. So always we use beta blockers, metoprolol, or esmolol or propanol or whatever you are familiar with it. And internal milieu is very important, hypokalemia, hypomagnesemia. So the treatment of polymorphic VT which occurs in the early phase AMI is multifaceted, and you have to target all these factors. Mere shocking the patient will not make the patient free of this arrhythmia. It may keep on recurring. And for those, particularly those who are revascularized in late, they continue to get this arrhythmia, and for that antisympathetic measures like left stellate ganglion block with xylocaine or thoracic epidural analgesia for T1, T4 blockage, or even stellate ganglion optimization, because sympathetic stimulation plays a very important role in polymorphic VT at the onset of acute myocardial infarction. Now this again is a simple ECG. You can see this is monomorphic VT, and this monomorphic VT, the treatment is little different. Acute attack, you always convert the patient by a DC shock. The drug of choice is procainamide, but not available these days. IV amiodarone can be infused, and lignocaine, the efficacy is only 30%. If it does not terminate, you can do an overdrive pacing, and for prevention, amiodarone plus beta blocker. But ICD is recommended for all these patients who have a documented attack of a monomorphic VT. The other issue I think all of us face in our day-to-day is hemodynamic instability. The patient is hypotensive, he is in shock. Now, if the subset of patient which is responsible for shock is correctly recognized, the treatment often produces fruitful result. But if you continue to infuse vasopressors and inotropes blindly, the patient will never improve. So let's see what are the subset of shocks. So when faced with a patient of acute myocardial infarction with shock, it could be a hypovolemic shock, it could be a cardiogenic shock because extensive damage to the ventricle. Sometimes pulmonary embolism is misdiagnosed or referred to as acute myocardial infarction, and we have several occasions where pericardial effusion, cardiac tamponade is sent to us as an acute myocardial because of hypotension and shock. So echocardiography is indispensable, and I think all cardiologists who are performing PCI or not performing, they must do echo themselves. You cannot wait for an echocardiographer to come to your rescue. Now, if the image is like this, small ventricles, hypercontractile, this is hypovolemic shock. This is an illustration from a patient post CABG who was put on a ventilator. They could not remove the ventilator, but when his fluid correction was done, the ventilator could be removed within 12 hours. So hypovolemic shock can also occur in acute myocardial infarction, may not be following CABG, but also if there's profuse vomiting following inferior infarction or drug-induced vomiting or whatever may be the cause, excessive sweating. So you must look for hypovolemia. This is the classical cardiac. You can see the hypokinetic ventricle is hardly moving. Large area of myocardium is affected. And the last one is, you can see right ventricle bigger than the left ventricle is likely to be pulmonary involved. We should look for a TR velocity at pulmonary hypertension, and uh, uh, you can see the clot here. And sometimes this pericardial effusion, cardiac tamponade from the periphery, is referred to us as acute myocardial infarction. But if you just put a probe, the diagnosis is very, very clear, and the treatment is immediate aspiration. So how do we differentiate between a pericardial effusion and a cardiac tamponade? In cardiac tamponade, you can see there is early diastolic collapse of the right ventricle. You can see in the moving picture also. And the other sign you should also look is this. Look at the atria which are like this. If there is pericardial effusion, there's inversion of these. This is the atrial wall. This is also the atrial wall, the right and the left. So they get inverted because of increase in the pericardial and the swinging heart. All these signs of uh, cardiac tamponade in a pericardial effusion. RA collapse is more sensitive, RV collapse is more specific, but you must remember if there is pulmonary artery hypertension or the RV ventricle is stiff, this RV collapse may not be seen. The other issue is the mechanical complication. They must be detected at the earlier if the patient of acute myocardial infarction, even after an angioplasty, suddenly deteriorates, or if the patient suddenly deteriorates, even in the cath lab, echo must be done. This is mitral regurgitation. This is ventricular septal rupture. This is ventricular septal rupture. Sometimes we even get rupture of the heart or pseudoaneurysms. And the last part of the topic is STEMI mimics, which again is very, very important. Time and again we see other conditions being referred to us as STEMI. Now this is an electrocardiogram from a patient who was referred to us for an angioplasty because of ST segment elevation. You can see ST segment elevation in multiple leads, but this ST segment elevation does not correspond to the distribution or the territory of any coronary artery disease. So that is the first suspicion, that this ST segment elevation is not due to acute myocardial infarction. And secondly, you can see the PR segment with the green arrow is depressed, and in AVR it is elevated, which again important sign of pericarditis. So this should be differentiated from pericarditis. This is of course hyperkalemia. Diabetic patient CKD came in altered mental state because of CKD, and hyperkalemia is the diagnosis. Now this is another patient who came virtually on the verge of death. The referring physician thought that this is ST elevation MI because of a Q wave and a upright T wave which is little taller, but and you can see QRS is wide, but this T wave morphology is because of hyperkalemia and not because of myocardial infarction. You can see T wave tall, they are symmetrical as you can see here, narrow base peaked with sharp apex, unlike hyperacute T wave of myocardial infarction which is asymmetrical, the base is broad and they are reciprocal. ST segment changes, they are no reciprocal. Potassium was very high, treated, and patient recovered. Now this patient had a cardiac arrest and was sent to us for an angiogram. But if you carefully look at the angiogram, this is not myocardial infarction, this is Brugada syndrome, and the patient needs an ICD and not uh, PCI. His brother died because of a cardiac arrest. That's why the patient was referred. Now, sometimes WPW syndrome was also mistaken for acute myocardial infarction. As you can see, uh, here is a WPW classical because it produces Q waves in the L2, 3, and ABF. This was mistaken for an acute inferior myocardial infarction. Now, this is again a very interesting case. In times again, we see pneumothorax, left side being referred to as acute myocardial infarction, but the easiest way not to miss a diagnosis of pneumothorax presenting as shock, just put a transducer on the left side of chest. If you are unable to see the cardiac shadow in absence of dextrocardiac or other pneumothorax should be sought, and if you put the transducer in an epigastric, you will see that the heart is grossly shifted. Now, this is again a very interesting story. A 60 years old male gets admitted with severe chest pain, retrosternal area of 4 years duration. A relation of the member of the medical fraternity. Repeated ECGs were normal. Repeated echoes were normal. Echo done by second operator normal. Serum markers for normal. Patient was shouting with retrosternal chest pain. Coronary angiogram was done, was normal. X-ray chest was done, and this is the X-ray chest. So what we should do, obviously this is not coronary artery disease, so we got a CT scan, and you can see here in the mediastinum, and this was the cause of chest pain. So sometimes these conditions also mimic as acute myocardial infarction. As you can see, the X-ray did give hint of here in the mediastinum, but was totally missed because we have not seen such case in the past. But in retrospect, it seems that this could be picked up, but I think unless you see more cases, this was missed. So thank you very much for your kind attention.
Thank you, Dr. Manoria, sir. That was a classical masterly teaching class as usual by you. Since there are a lot many interventional cardiologists here, any comments or any clarifications? One or two.
Sir, it was excellent talk, sir. Like we all enjoyed your teaching. Basically, we never these days we never speak about ECG and minute changes. I just want to ask regarding the pulmonary embolism. So many patients we see in our practice that the patients referred with an history, I mean, features of acute coronary syndrome, and that turned out to be acute pulmonary embolism. Can you give a small thought about that, sir? Like there will be T wave inversions in V1 to V3 and all.
See, besides CCG, echo is mandatory as a screening procedure for pulmonary embolism. The right ventricle will be dilated. You will also see a TR jet more than 2.5. The velocity is more than 2.5. And in a given clinical case, in the clinical scenario, pulmonary embolism has to be strongly suspected. You can ask for a D dimer, which is usually very high in these patients. So that is the simplest. Sending the patient for CT angio is not always feasible unless you have a CT angio in your lab. So that is how we suspect, and many of these patients, as you rightly said, are referred to as acute myocardial infarction because they are in shock, there are changes in the electrocardiogram. But if you screen with an echocardiogram immediately, I think the suspicion is always there.
Okay, sir. Thank you.
And you can look for a DVT or other cause for pulmonary embolism.
Support evidences. Are there any questions from the audience?
So thank you, Dr. Manoria, sir, for sparing your valuable time.
It was my great pleasure.
Yeah, thank you.
Thank you, Dr. Shankar, Dr. Everybody. Nice to see you.
Dr. Antani, sir, your comments, anything? Kindly,
Dr. Antani, nice to see you.
yeah. Kindly unmute Dr. Antani.
Very practical talk, very useful.
Thank you. So now we move on to the next talk. We'll move on to the next talk. That is present status of robotic heart surgery in India by Dr. Vivek Jodi, sir, Chairman, Executive Council of Fortis Hospital, Bangalore. I would request the chairpersons, Dr. Shivraj Alsheti, sir, Dr. Moinuddin, sir,